To start everything off, I thought that we could just go through and each say one positive impact that you think the ACA is going to have on the state and one negative impact. So hopefully we can just keep this a little bit brief and get things going. Would you like to start, Representative Bonnen?
Absolutely. So I think a positive aspect of this is that, frankly, we would not be having as extensive or in-depth conversation on healthcare or on the issue of the uninsured were it not for these policy initiatives that we're now having to to wrestle with. I do have concerns about the potential fiscal implications in the state and also whether this is the most efficient way to address the problem. And I'm sure we'll have plenty of opportunity to discuss that as we go through this session.
John?
Well, I agree with Dr. Bonnen's statements, but let me say what I believe is one negative impact or three negative impacts of the Affordable Care Act. I think, I'll just limit to three for now, but I think as we move forward toward implementation, I think you're going to actually see an increase in the number of uninsured, an increase in unemployment, and what we've already started to see is an increase in premiums. And the good thing about this is that it will become clear what a disaster the Affordable Care Act is going to be. So I'll start with that.
All right, Anne, would you like to counter?
I'm going to try to avoid countering, but I think the big picture positive thing I would focus on is that with all the difficulties we may have implementing this law, this imperfect law, that our former state demographer and the former head of the U.S. Census, Steve Murdoch, and his colleague Mike Klein have estimated that with just moderate take-up rates, we will cut our uninsured rate in half in Texas. And if we have robust take-up rates, we'll reduce it by about 75%. And that can be transformative for all kinds of people, which I'll hold and talk about later. And then in terms of being, intellectually honest and focusing on one of the problems with the ACA, I would say the affordability glitch for families is something that concerns me. It is the IRS's interpretation that as long as my employer pays 100% of my premium, it wouldn't matter how much of my income covering my spouse and children took up. It could take up half my income, and theoretically, they still wouldn't qualify for sliding scale help in the exchange, that it's only based on my premium. And so I think that some people who very legitimately need access to sliding scale help with premiums under the current interpretation of the law are going to be left out.
Well, I think the advantage is 1 million Texans with insurance that don't have it now and who are relegated to going to emergency rooms, which is putting a crushing burden on counties and local hospitals. And we can deal with the problem now, or we can deal with it later when it's a problem of higher property taxes or overburdened local health systems. This is an opportunity, whether we go by Dr. Zerwas's ideas or Arkansas, any of these other alternatives, but this is time to have this. This is the time to have this discussion. I think the downside, to take a cue from earlier ones, is an interesting glitch in this whole situation that Jackson Hewitt Insurance Services has identified, that if we don't do the expansion, Texas employers are going to pay somewhere between $300 and $500 million in penalties for some of their employees that get premium assistance directly from the federal government, which we won't be able to control here at the state. So Texas employers are going to feel some of the effect of not doing this.
So Texas has the highest rate of uninsured in the nation. Depending on who you ask, it's a quarter to a third of our population and more than 6 million people. This law obviously has a lot of ways to reduce that. Could you kind of give us some examples of what the law is going to do to bring down the uninsured rate in Texas and the overall impact that that's going to have on our insurance market?
I think that's a very complex question, and the Affordable Care Act is obviously a huge piece of legislation with many initiatives and many working parts. So you really, I think, have to break that down into its different components. And the larger components, which have been mentioned earlier this morning, of course, we have the insurance exchange, which is scheduled to be implemented later this year by the federal government. And then we have this debate centering around an expansion of Medicaid or some other form or effort to provide for those essentially under 100% of the federal poverty level. So given the fact that we know that the federal government is going to initiate this exchange, when you look at the statistics, you actually see that the projections are that's where we're going to see the greatest impact. You're going to see the largest number of people who are currently uninsured become insured, and you're going to see the largest amount of revenue infused into the system through that component as opposed to a further expansion. And we could go on for quite some time, but I'd like to let the other panelists weigh in on that, and then maybe we can have some dialogue.
Yeah, I'll just pick up where you left off. Representative Bonnen's referencing some discussion that's been happening recently in the legislature for some committees, and HHSC has weighed in on this, saying that they predict other pieces of the Affordable Care Act will work to reduce the uninsured rate in Texas, notably the individual mandate. And their projections are that without Medicaid expansion, the uninsured rate will fall to 15 or 16%, just with these other provisions in the law.
Could you give us some examples of what those provisions are for people that don't know?
I mean, well, the individual mandate, of course, is that you have to be insured after January 1, 2014, or you pay a fine. The federal exchange for states that don't expand Medicaid will make premium support available to anyone from 100 to 400% of the federal poverty limit. For states that do expand, it's 138 to 400. I can tell we're going to get pretty wonky here. But interestingly, for states that don't expand Medicaid, they have a greater number of people who are going to go into the federal exchange. I think the estimate in Texas is about 250, 260,000 people that fall between that 100 and 138 percentage that would be eligible for premium assistance in the federal exchange if we don't expand Medicaid. The total number of people in the exchange, if the exchange gets up and running, would be 2.5 million people, and so that is a far larger group than the expansion group that we're talking about, and that is where you'll see the greatest impact immediately from these provisions of the Affordable Care Act, with or without Medicaid expansion.
Mr. Hamilton, I mean, you've written a report that says depending on how Texas implements the Affordable Care Act, it could vary the impact on how much our uninsured rate goes down. Could you kind of explain what you found?
Well, remember, we were mainly looking at the Medicaid expansion, which is only a part of it. But there's about a 1.4 million, I guess, adults that fall into the 138% of poverty or less. We did estimates that suggested about 1 million of them, taking our cue from Health and Human Services Commission, would be able to have access to health care. I think the most important innovation here that doesn't get a lot of attention but gets a lot of criticism is Medicaid is always said to be a broken program because there's not enough doctors that accept Medicaid. And that was an issue that concerned me because we were looking at it cold. But really what we found was part of the problem is that the doctors are simply not compensated near the Medicare rate. And one of the things Affordable Health Care Act does is raise provider rates. And that we would think would, if you follow simple economic logic, you think that's going to attract more doctors that will cure that very real problem with the system as it is.
Yeah, so, I mean, speaking to that point, the Affordable Care Act has a lot of quality improvement measures that's supposed to improve the quality of care. How are these already impacting our medical system in Medicaid and just in the private market?
Yeah, before I try to speak to that, and there are a lot of quality improvement measures that I don't know if I would even describe them as entirely being attributable to the Affordable Care Act, but But to rule implementation or statute beyond that, that's an initiative that's been going on for a number of years now. But I do think that there is a real concern about provider participation in the Medicaid program, and there is also a risk that if you try to explore why is that a problem in Medicaid, well, it becomes a matter of what services are you providing into what volume of people, and how do you spread those dollars out, and ultimately the revenue's not there to compensate the providers at the rate that you would like to. That causes me also further concern when I think about the exchanges and very prescriptive and specific requirements are what are going to be in the insurance products that are obtained through these, and then the amount of money that is being implemented through those exchanges for those products. Again, where will the cost savings be absorbed? If it's absorbed, as it is in Medicaid, largely by the providers, then you have huge discounts being absorbed by those individuals, which leads to difficulty with access, and you may not get the result that you are intending or desiring.
Ann, do you want to jump in?
There's so many places I could jump in, and I'm not even sure which question we're answering at this point. One thing I would want to say is that not everybody says Medicaid is broken, and I think that if you talk to families that rely on Medicaid to take care of their children, and seniors who rely on it, and people with disabilities who rely on it every day for attendant care so they can get out of bed and into their wheelchair, they don't think it's broken. They think it needs to be improved, just like our public schools need to be improved, just like Medicare needs to be improved, but it doesn't need to be shut down just because it's not perfect yet. I think that with respect to, I think your original question was around getting to some efficiencies and savings, and I don't claim to be a special expert on that, but I will say that if you had somebody up here on this panel from the hospital industry, they could probably rattle off 12 things that they've already been dealing with for several years, all kinds of reductions in payment for potentially preventable readmissions and never events and those sorts of things. So, part of what we're trying to do is really ratchet up patient safety. But I think that the hospitals are probably also eagerly awaiting more of a world where the entire array of healthcare providers, which would include the health plans and HMOs themselves, are kind of on the hook for making sure that people have coordinated care and resources being devoted to keeping people from going back to the hospital when they don't need to. And changing, which is painful and hard, some of those financial incentives so that you can't make money just from avoiding taking care of people, and you can't make money just from giving people stuff they don't need. That's the holy grail. We're not there yet, but those are the hard changes that are sort of in the pipeline.
If I can
go ahead.
Your question was specifically about what are the cost or the quality improvement measures. Some of the quality improvement measures, as Representative Bonnen referenced, are the provisions in the exchange, the essential health benefits. These essential health benefits are essentially a list of benefits that health plans in the exchange must include in order to be eligible to be on the exchange and to receive a federal subsidy. And when you look at these health benefits, they may or may not improve quality, but they do, and they are going to drive up cost. And so what you're seeing in the exchange is an expansion in some ways of what we've seen in the Medicaid program. One of the problems with the Medicaid program, of the many problems it has, and even if you don't agree that it's broken, HHSC has testified before committees this session, and I think most people would agree that it's fragile. There's a problem with access. There's a fragile network. Medicaid needs reform. It doesn't need to be shut down at all. It needs to be reformed so it can be preserved, so it can be sustainable in the long term, which right now it's not. Texas is in the middle of a steady long-term rise in our Medicaid expenditures, such that now the Senate budget that was just passed has more money appropriated to HHSC than it does for K through 12 education. And that trend is going to continue without substantive reform. And one of the things that needs to be reformed is this entitlement to benefits in Medicaid. The state doesn't have flexibility to tailor or scale back the benefit plans so that people just get the care that they need and want. They're not an entitlement to a whole suite of benefits in the plan, and that's what we were seeing in the exchange, and that's one of the things that insurers are saying is going to drive up the cost of premiums on the exchange, such that, as Ann mentioned, people who are looking for insurance on the exchange for their families are going to be priced out of it, because while their employer may cover their premium, the family premium is going to be so high, and it's going to be driven up even higher with these benefit guarantees that they're not going to be able to afford insurance.
Yeah. I mean, as we kind of brought up in the last panel, Texas decided not to take over and set up the federal health or the health insurance exchange, but the law is going to require that all the plans in the exchange have a bunch of provisions and offer certain benefits, and they don't deny people for preventative care. How overall is this going to impact premium rates and Texas insurance market and insurers in Texas and access to insurance?
I'm going to jump in there and say almost any of the economic issues that Mr. Davidson has raised we could talk about for an hour, and I would say that to the audience that if you're interested in reading some analysis by economists of those issues, the Urban Institute's website is one of the best places to find that. So I couldn't possibly sum it all up in one piece, but the essential health benefits, I think one of the most important things to understand is there's sort of like 10 basic categories of benefits, and basically what they're saying is you're not going to be able to sell health insurance that doesn't cover mental health anymore. You're not going to be able to sell health insurance that doesn't cover prescription drugs. You're not going to be able to cover health insurance that doesn't cover mental health or maternity. You know, all of these pieces have to be there, but the benchmark that we're using is a state benchmark. It's the most popular Blue Cross Blue Shield small group product. So to suggest that there's going to be some dramatic sweeping overnight exchange in the content is not accurate. I think the one area where we're going to see the biggest change in the content is going to be because in 2014, those essential health benefits and most individual and small group coverage is going to have to comply with mental health parity requirements. And we don't have the final regs on that, so we don't really even know how strong that's going to be. But you're not going to be able to essentially treat mental health treatment as kind of a second-class benefit anymore.
So a lot of, as we kind of mentioned earlier, a lot of the hospitals are already taking cuts to finance a lot of the provisions in this law, and they're dealing with these changes already. They've come out pretty strongly as saying this is why we need to expand Medicaid, because otherwise we're going to miss out on billions of dollars. I mean, how much money do you think Medicaid would bring, or Medicaid expansion or some alternative to Medicaid expansion could bring to the state, and what impact would that have on our healthcare system if we did or didn't find a way to get this money?
Well, I think there are a number of points to be considered there. And to return to one of the first things that I pointed out, the greatest infusion of money into the system is actually going to be through the uninsured who become insured through the exchange, not through the expansion. When you take that also into consideration with the 1115 transformation waiver, you're talking about two separate policy initiatives in the same policy area that are multi-billion-dollar initiatives. And if you add Medicaid expansion to that, that is a third multi-billion-dollar initiative within the same policy area. While the first initiative is not halfway implemented, the second one hasn't begun, and we're talking about doing a third. I don't know that that's very wise. You also have to consider that providers such as myself or hospitals or other facilities, we respond to the changes in our reimbursement environment, and then our business models are built around those changes, and then trying to unwind that becomes incredibly difficult and incredibly complex. So one final point I do want to put out there before we leave is we're talking about this within the context of government regulation of the market and government subsidized programs, but I think we really need to talk about the private healthcare market and what's happening there, because the price and the cost of healthcare has gone up to just unacceptable heights. And physicians actually are not the beneficiaries of that, I can tell you. So it would be really great if we could shine the light of day on where our money is going in healthcare, if we could instill some true free market principles into the healthcare sector of our economy. You would see pricing come down, and that is very germane to what we're talking about today, because that leads to the care truly being more affordable, thus the Affordable Care Act. And you have fewer uninsureds, and you have more people that can actually afford the price of care. So the two essential components to that are we have to know up front the price, the true price of what we're choosing to purchase, and we have to have some personal investment. We have to have skin in the game so that we or are motivated to make a wise decision. So we can address some of the major issues that we have by dealing with the private sector apart from just focusing on federal or state initiatives for subsidized programs.
So want to jump in and lobby Representative Bonnen on Representative Smithy's balance billing bill now for transparency and pricing, but we'll get back to that. One of the things I wanted to mention, going back to the previous comment, is actually if you look at the Texas Medicaid expenditure data per capita over the last decade or more, if you adjust it for inflation, the actual expenditure per person has declined, not gone up. Our increase in spending in Medicaid is entirely related to increase in enrollment, so it's all tied up with the growing, spiraling problem of people not being able to afford insurance. And employer-sponsored insurance has declined in every state of the union except, guess which one, Massachusetts. So, this is part of a bigger trend in terms of healthcare costs. You asked about the effects. The Health and Human Services Commission, not me, has estimated that over the first 4 years, that the federal funds that would come in if we did Medicaid expansion and if it enrolled about 1.1 million adults, as Billy Hamilton mentioned, that it would bring in about $24 billion in federal funds over that period of time.
Yeah, Mr. Hamilton, you've called this a great fiscal opportunity for the state and some of the legislative hearings. Could you kind of explain, from a tax and fiscal perspective, why?
Well, we just, in our study was sponsored by Texas Impact and Methodist Healthcare Ministries, and their interest was that they are the people at the bottom of the current system we have now that are being crushed by these costs. So they just wanted to know if this was a legitimate option. So I said, we'll look at this from the standpoint of a business case. Is there a business case here? And I have to tell you, unlike Ann, my specialty is taxation and the budget. It's not really this issue, so I came with relatively fresh eyes. And this is our estimate, which tracks, I think, HHSC, is $100 billion in 10 years, 1 million adults on insurance that don't have it now. Even if you treated the first 3 years where the federal government will pay the whole thing as a COBRA and just said to these people, you have insurance, health insurance, access to health insurance that doesn't involve going to an emergency room and sitting next to a person that's been knifed in a knife fight or something like that, that you can get health insurance just like the rest of anybody else, all other Texans. And in that period of time, we should help them get jobs or get more education, do whatever the Health and Human Service system does to help them and move them toward independence. Even if we just did that, as Ann said, it would be $30 billion over those 10 years that the feds would pay for fully. This is not being paid for by China. It's not being paid for by borrowing. It's being paid for by taxes and fees that all of us, and especially me and my income bracket, are going to pay. And what we're talking about is trying to take advantage of the fact that we're going to be paying a tanning tax and we're going to be paying higher Medicaid taxes and we're going to be paying fees on our employees that can't access insurance through our companies. We're going to be doing that anyway. We might as well get this back and try to make a dent in the fact that we are the state that has the highest number of uninsured. And, it's been a joke on the fiscal side of the budget as long as I've been in government that, we say, thank God for Mississippi. We can't even say thank God for Mississippi in this case. So, we need to make a dent in this problem just like we need to make a dent in water and transportation. And that's why I'm glad to see Dr. Zerwas and Dr. Bonnen and the rest of the House at least willing to talk about this issue.
I do think there's some important points we do need to consider there, which is, again, apart from an expansion of Medicaid for that 100% and below, when you speak of a county taxing entity, for example, much of the care they provide, and this is, of course, individual to the given counties, it is actually outpatient. It's not all emergency room hospital-based, and depending on the individual program, they may have a threshold of up to 200 or 300% of the federal poverty level. So when you implement the subsidy program, you are actually relieving them of that burden from 100% to whatever the upper limit of their program is. So there is relief actually on the way, even without an expansion of the Medicaid program. And I would, also have to add that as a neurosurgeon, as a physician, we have all sorts of peer-reviewed articles and studies that we do. And when we see a pharmaceutical company that sponsors a study, even by very well-esteemed and respected colleagues, we take that study with a tablespoon of salt. And so you have to consider who's paying for the study and what is the message that they're trying to portray. And then you start looking at what is the actual uptake rate? What is it we're trying to predict? And this is where I would say, look, we've got billions of dollars that are going to flow into our healthcare system in Texas. If we frankly don't take any further action, maybe it would be wise to let some of these initiatives actually be implemented and make an intellectually honest appraisal of or reassessment of the situation. At that point, we didn't get into this situation overnight, and we don't have to fix it overnight. It would probably be unwise to attempt to fix it all in a short period of time. So that would just be some of my perspective on that.
And the money that you're talking about, the other initiatives, which were about a year and a half into the 1115 transformation waiver, we've got 3.5 years to go, and $29.5 billion that we can, of federal dollars that we can pull down. And so at some point the question becomes, how many billions of dollars do we need to provide care to this group of people?
And another $8 billion over the next biennium, potentially in the insurance exchange.
Absolutely. So you have, and the specific purpose of the 1115 transformation waivers is to increase access to primary care and preventative care on the local level. That is the goal of the regional health plans and the regional health partnerships. There's 20 of them around the state using those IGT funds that Representative Coleman and...
But Texas isn't necessarily guaranteed to get that money.
No, but they're working hard to get...
I need to clarify, the $29 billion is the entire budget. Only $17 billion of that is federal. The state has to put up $12 billion to draw down
So
17.
for anyone that doesn't know, the 1115 waiver, the state requested from the federal government last session, and it's going to potentially infuse about $29 billion for indigent care. But regional systems in Texas have to gather up local tax dollars, set up these programs, and then if they're successful, they can draw down the federal money.
Which they're doing right now.
The waiver concept includes, and the waiver application, which was approved by the feds, was done long before the Supreme Court decision, and it assumed that Texas would be expanding Medicaid. And the intention of the waiver, which was based on a structure that California used and a waiver that was called Bridge to Reform, assumed that Medicaid expansion would be part of that picture. It doesn't provide any coverage. It anticipates building capacity so that when people do gain coverage in 2014, there will be systems there to serve them.
So that's another point about the ACA. The Medicaid expansion wasn't supposed to be optional, but it is now because of the U.S. Supreme Court decision. And one of the things that's come up a lot in the legislature is this population that's just between qualifying for the exchange or Medicaid expansion potentially if it existed, and therefore some of them could go into the exchange if we don't do Medicaid expansion, but anyone below 100% of the poverty line doesn't actually qualify for any of these subsidies. And so many people have made the argument that the 1115 waiver programs will cover this population and there's other money, but what's going to happen to these people who are still underserved and the very, very poor if we don't expand Medicaid?
Well, first of all, I think you need to look at the demographics. So we're talking about non-disabled adults. Approximately 80% of them are under the age of 50, and approximately half of them are actually under the age of 35. And again, no insurance doesn't always mean no care. And so there are county programs that do provide not only coverage for when they appear in the emergency room, but actually outpatient services for these individuals. So I think I agree that we want to ultimately address that perhaps more definitively, but again, there are a lot of very, very big moving parts and a lot of initiatives that have not even begun to go to work. So I think we should be thoughtful and cautious as we make these investments and move forward. And I don't think that they're going to be completely left without care, even if they don't formally have a commercial insurance card.
Yeah, and the notion, I think, that expanding Medicaid is a panacea for this problem of the uninsured, this problem of uncompensated care, is a wrong way to approach it. Putting 1 million, or I guess at some estimates 1.5 million people into an unreformed Medicaid system will strain the safety net to the point where access will become progressively worse for the people who are already on Medicaid, and leave people who are newly eligible with very poor access to care. And I think, one of the things that gets lost in the constant debate about whether to expand Medicaid is a much more important conversation about what to do about Medicaid for those who are currently on it, who have subpar access to care, who have worse health outcomes, far worse than those on private insurance. And one of the things that was brought up earlier that I want to try to get back to is this notion of sort of fundamental reform of the healthcare system. The fundamental reforms that TPPF advocates for Medicaid are very similar to the things that need to happen that Dr. Bonnen touched on in private insurance and private healthcare, which is reducing that distance between the patient and the provider. We have this third-party system that hides costs, that distorts the free market, that distorts incentives, so that a private patient really has no sense of how much money is changing hands. They only know their copay or their deductible. They don't really know where the money is going. And I don't think the public really knows where the money is going. And reducing the distance between provider and patient is the way forward for reform and cost control, really. And that is what needs to happen with the current Medicaid program.
And I have to add, the providers don't know the price, sadly, much of the time. And it's really just amazing to me that we can have proprietary pricing that is held in secret by a third-party intermediary, and then even imagine that we have anything that resembles a free market. That is a problem that I think needs to be addressed that would have a huge impact on healthcare in the state.
I would certainly agree that the market's really distorted and has lots of problems. Just want to make 2 quick comments. One is that the notion that Medicaid has worse outcomes has been thoroughly debunked. You can go to the National PolitiFact website and see a complete deconstruction of that claim, where they've interviewed the authors of all of the research that was cited, and they've said that that was a misinterpretation. So it'd be really nice if we could lay that one to waste. And then we are an organization that was founded by Benedictine sisters. So clearly we're mission driven. And to us, it's okay to just say out loud that we don't think it's acceptable, with all of these federal dollars on the table to take care of our poorest uninsured, to suggest that because we're going to get a lot of money coming in through the exchange for sliding scale subsidies for those people, and because we're going to cover some higher income people in the exchange, that it's okay for us to just leave 1.1 million potentially eligible below poverty adults without coverage. So I really just feel like that needs to be part of the discussion, to suggest somehow that the fact.
I guess we're down to me. Well, I think we all understand that the legislature will decide this issue, and it's not. We've make our case, and what I've worked in public policy in this state for several years now, and the one thing, the 2 things I've noticed about large public policies is it's never a good time or convenient time to do hard things. And you can see the legislature struggle with this now. I mean, we need to do something about water. Well, it costs a lot of money, the spending cap's in the way, and you see people of good intent struggling with what are essentially technical issues standing in the way of the fact that West Texas may eventually just sort of dry up and blow away. And public policy is hard, and this is a hard issue, and of course it's not convenient. The thing I go back to is something Sylvester Turner said in one of the first hearings on this, and he asked, somebody that was testifying that the state had a plan for addressing Medicaid expansion, or at least addressing the idea of Medicaid expansion. They said, well, we don't actually have a plan, seemed to be the gist of it. And he said, Arkansas has a plan. And, I think that's the issue. And, I keep going back to, I'm glad Dr. Zerwas is saying, let's at least have this discussion. But when you're taking $100 billion and you're just saying, well, it's too soon, we're not ready. Well, that was the issue that compelled Methodist healthcare systems, and they're our sponsor, and yes, they're in the system in a certain place, and they have an opinion, but they didn't ask us to form any particular opinion on our study. But the issue that they were trying to get at was nobody was talking about this, and it's arguably one of the most important public policy decisions we make, for good or ill, Because the second thing I learned about public policy is all these big programs are messy to begin with, and they've got to be fixed. But you can't fix a problem unless you get underway and see what the actual issues are. If we're sitting on the sidelines in 5 years, then we can make jokes about California, I guess, because that'll be where we are.
Yeah, and we're clearly not on the sidelines. Apart from this whole notion that if we don't expand Medicaid right now today, we're on the sidelines, I think that's false. Again, I think with the 1115 transformation waiver, with the federal insurance exchange program that's going to be implemented, we are anything but on the sidelines. We are in the middle of dramatic change that is occurring right now. And whether we implement further initiative next year or 2 years from now or 4 years from now, I don't think that's been because we've been standing on the sidelines. And I think sometimes when you're in the middle of really substantive, dramatic change, which we are, that it is wise to occasionally pause and take inventory and see where we are, how should we proceed, what really makes sense. So that would be my caution and my response. And again, I can't say more clearly that it is just really inaccurate to say that if we don't expand Medicaid, we've done nothing, and that nothing is changing in the state with respect to health care. I just think that's not true.
And I think it's a misrepresentation to cast opposition to Medicaid expansion as opposition to health care reform. Those are not the same thing. And it's come up a couple times, and really quickly, Arkansas has come up a couple times. I got to say something about Arkansas. Everyone says, well, Arkansas has a plan. Texas doesn't have a plan. Those poor, benighted Arkansans have a plan, and we don't. Why is this? Arkansas's plan is really the worst of both worlds. Arkansas's plan doesn't even require a waiver. They've asked to use premium assistance to provide for the Medicaid expansion population, which you can do without a waiver. Late last month, CMS issued a sort of a FAQ about Arkansas, clarifying, just so everyone understands without any doubt, that whatever premium assistance that Arkansas provides to the Medicaid expansion population and whatever private insurance plans that those people get on, the state of Arkansas will have to provide wraparound benefits for anything the private plans don't cover that the normal Medicaid plans do cover, which is going to represent a significant cost to the state of Arkansas in the short term, and in the long term, when the federal support begins to decline after 2017, is going to represent a significantly larger portion of the state share that they'll have to contribute. So this notion that, well, we're putting them onto private insurance, they're not on Medicaid, CMS has been very clear about that there is no such thing as that. You can put them onto private insurance, but the state has to provide all of the Medicaid benefits that they would have if they were on the normal Medicaid program, and they were very explicit about that.
And to clarify, the one benefit that would not already be included in an essential health benefits package, which is pretty much the same standard between the Medicaid expansion group and the exchange, is medical transportation. So basically what it would mean is that, you know, the Arkansas can enroll these folks in the exchange, but those people will also, in that expansion group, will also have access to the medical transportation program that's available to the rest of their Medicaid program. So it's not quite as tortured as you might think. It's not like there's a bunch of exotic benefits other than that have to be added.
One other thing I just want to mention about this $100 billion is I understand that that's a projection over 10 years, and it's based on an uptake that is probably it is higher than what others would project as the uptake into that program, and it's really not free money. I think we have to keep that in mind. When we look at the proportional funding in our current programs, it's about 60% federal, about 40% state. So the idea that this is going in perpetuity to be a 90% federal subsidized program, I think that's a very dangerous assumption, and we need to be cognizant of the fact we could leave ourselves on the hook for billions of dollars if we go down that path.
That was a concern that was raised when Texas was looking at whether or not to create a children's health insurance program back under then Governor Bush. And in our Texas CHIP law, we added a provision, as several other states have now in their Medicaid expansion provisions, that just says if there is a change in the federal commitment, we can shut the program down.
The problem with that is you'll never
And of course, there
shut it
hasn't
down.
been a change in the CHIP program. They've kept their promise on that. So.
But not at 90%.
Perhaps not, but it hasn't happened yet. And the other states, I think the big lesson from Arkansas for me is that for any state that really wants to get to yes and is willing to actually do some compromising, not just demanding, there's a way to get there with a conservative solution. And there's really no excuse for Texas not getting there.
I would agree that may be very much the case, and it's not something that has to happen by the end of May.
I would not agree that it's acceptable on January 1st of 2014 that everyone in Texas with an income above 100% of poverty who doesn't have access to affordable employer-sponsored insurance has access to sliding scale taxpayer-funded assistance through the exchange, but there is nothing there for the people below poverty because we made this ideological choice, particularly when there are conservative solutions available to us. And so I hope that Chairman Zerwas's bill can lead us towards some kind of compromise that represents something that states like Arkansas and Arizona and Florida can live with.